Today we are looking at the platelet disorders. So to start with, going by a few questions. So firstly, what is the defect that is seen in case of the Bernard-Solier syndrome? Next question. What is the mechanism of the Glanzmann thrombasthenia? Thirdly, in case of the von Willebrand disease, what is the platelet count? Is it increased, decreased? So we'll find the answers in this video along with a lot more. So firstly, we are looking at the disease of the Bernard-Solier syndrome. So this is, it is nothing but AR, that is autosomal recessive, and the defect is of there is an absence of the GP1B95 receptor. Then we move on to the mechanism. What is the mechanism? Mechanism is that there's a lack of the GP1B95, and it prevents the platelet adhesion to the von Willebrand factor. Next, we are looking at the PC, that is the platelet count. Platelet count, it remains normal, as well as there is mild thrombocytopenia. Next, we move on to the platelet morphology. So in case of the platelet morphology, there are presence of large platelets, as well as there are the mega thrombocytes, and they have presence of the dense granules. Next, we look at the bleeding time. The bleeding time, it is prolonged. And looking at the platelet aggregation, so the platelet aggregation test, this includes the ADP, the thrombin, as well as the collagen. So these remain normal. Next, we look at the ristocetin aggregation test. So here it is abnormal, that is, there is the platelets, it does not aggregate. Then we look at the von Willebrand factor levels. So they are nothing but it is normal. And next, in case of the PT-PDT, it is also normal. Next, we move on to another disorder, platelet disorder. It is known as the Glanzmann. Okay, it is known as the Glanzmann's thrombasthenia. So in case of the Glanzmann thrombasthenia, this is again AR, that is autosomal recessive. The defect, it lies in there is absence of the GP2B as well as the 3A receptor. Then what is the mechanism? Mechanism is that the platelets, it cannot aggregate. The platelet, it cannot aggregate. Okay, as the GP2B and the 3A, they normally, what they do is they bind to the fibrinogen and it forms bridges. it forms bridges between the platelets. Then jumping on next, looking at the platelet count. So platelet count here is that it is normal, and in case of the platelet morphology, it is again normal, and looking at the bleeding time, it is prolonged. And looking at the platelet aggregation test. So this can include the collagen, ADP, as well as the thrombin. So this is abnormal. Then we move on to the ristocetin aggregation test. So here the result is that it is normal. That is, there is presence of the aggregation of the platelets. Then we look at the VWF levels. So in case of the VWF factor levels, so here it is normal. And then looking at the PTT, this is again normal. Lastly, we will focus on the disorder, that is the von Willebrand disease. So first, as we discussed, what is the inheritance pattern? So it is most common type 1, and this is of the autosomal dominant AD. And what is the defect? So the defect is that it has, in type 1, there is a partial quantitative deficiency. So the partial quantitative deficiency is of the von Willebrand factor. Next, looking at type 2. So type 2 has a qualitative. In type 1 it was quantitative, here it is qualitative defect of the von Willebrand factor. So there are not just 2, there is another one, 3 in case of the type 3. So in case of type 3, there is a complete quantitative. This is the deficiency of the VWF, von Willebrand factor. Next, we look at the mechanism. How does it work? So in case of the mechanism, there are 2 mechanisms. So looking at one, there is the platelet adhesion defect. So there's a platelet adhesion defect, and this is due to the absence. There is absence of the von Willebrand factor, which usually it binds to the GP9 and the collagen in the subendothelium. Next, due to the factor, this is factor 8 deficiency, and this is as the von Willebrand factor, it usually prevents its degradation. Then we look at the platelet. So looking at the platelet count, okay. So in platelet count of in case of the von Willebrand's disease, it is normal, except there's an exception, except in type 2B, which shows the thrombocytopenia. Next we look at the platelet morphology. So in case of platelet morphology, it looks normal as well as it can be large. Then we look at the bleeding time. So bleeding time, it is prolonged. Next, we look at, in case of the platelet aggregation test, which includes the collagen, the ADP, as well as the thrombin. So in such case, it is normal. And next, moving on to the ristocetin, and this is nothing but the ristocetin aggregation test. So here, what we see is, it is abnormal. And what it does, it is normalizes after the addition, after you add the normal serum. Next, looking at the VWF levels, factor levels. So here, what happens is, it decreases. Then looking at the PTT levels. So PT is generally normal, whereas the APTT is prolonged. So now to answer the questions which we asked in the start of the video. So the question was, in case of the Bernard-Solliers disease, that is a syndrome, what is the defect? So the defect here was the absence of the GP1B95 receptor. Next, we look at the Glanzmann's thrombasthenia. So in the Glanzmann's thrombasthenia, what is the mechanism? So here the mechanism was that the platelets, it cannot aggregate, as the GP2B as well as the 3A. So the GP2B as well as 3A, it normally, what it does, it binds to the fibrinogen. And what it does, it forms bridges between the platelets. That is a mechanism. Next, moving on to the von Willebrand's disease. That was the third question which was asked. So here, the platelets, if you see the platelets, it is normal. Whereas in case of the exception, there's an exception. That is in case of the type 2B, there is thrombocytopenia.
Hello everyone, this is Dr. Hub. Now let me tell you our story. Running with us, we are sure you will reach your destination with ease.